Good morning. Welcome back to class. Do you remember being a little kid, standing on the front lawn with your arms stretched out wide and spinning around and around and around until you felt dizzy enough to fall over? It was such fun. Let me tell you, having that sensation as an adult while sitting still is not so fun. One morning last month, I sat up in bed and felt like I was on a tilt-a-whirl. It wasn't the minor type of disorientation that we sometimes get from sitting up too quickly. It felt like I had consumed an entire bottle of wine. When I stood up to start my "it's time to get ready for work" routine, I had to hold onto the walls and the furniture around me to walk. If I would sit still or lie down in one position for some time, it seemed that the spinning would stop. But as soon as I moved my body, specifically my head, the room turned back into a merry-go-round. What's more, the frequent spinning sensations were making me feel nauseous. If you haven't figured it out yet, what I was experiencing is a sensation called vertigo, caused because my sense of balance was impaired. Good balance is often taken for granted. Most people don't find it difficult to walk across a gravel driveway or transition from walking on a sidewalk to grass, or get out of bed in the morning without stumbling. Balance is the ability to maintain the body's center of mass over its base of support. A properly functioning balance system allows us to see clearly while driving or any movement, identify orientation with respect to gravity, determine direction and speed of movement, and make automatic postural adjustments to maintain posture and stability in various conditions and activities. Balance is achieved and maintained by a complex set of sensory motor control systems that include a sensory input from vision, proprioception from touch, and a system in your body that we will talk about today called the vestibular apparatus. The vestibular apparatus is located in your inner ear, and it provides sensory information about motion, equilibrium, and spatial orientation to the brain, all of which are required for maintaining your balance and allowing you to perform coordinated movements. As I mentioned, our focus today is on the vestibular apparatus, which is essential for normal movement and equilibrium. We will go more into depth about what the system is, then examine the system's various structures along with their specific functions, look at the 3 types of reflexes associated with the system, discuss the connections made between the nervous system and the vestibular apparatus, and briefly describe some dysfunctions of the system, most of which often have those symptoms of vertigo I discussed at the very beginning. The vestibular apparatus is a complex sensory system that involves communication between the peripheral vestibular apparatus, the ocular system, postural muscles, the brainstem, cerebellum, and the cortex. The inner ear, known as the labyrinth, contains 2 primary structures: the cochlea, that's responsible for hearing, and the vestibular apparatus, which is the non-auditory portion of the inner ear that detects head motion and gravitational forces on the body. Vestibular centers in the brain allow us to process the sensory information provided by the vestibular apparatus. This allows the body to maintain posture, balance, and proper spatial orientation during movement, as well as the correct positioning of visual images during motion by stabilizing in space the fixation point of the eyes when the head moves. This provides a stable image upon the retina of the eye. The inner ear is called the labyrinth because it consists of channels and chambers hollowed out within the temporal bone of the skull. We discussed the basic design of the labyrinthine organs last week in relation to the auditory structures. The vestibular apparatus consists of the same tube within a tube construction. Remember the membranous labyrinth, that's the blue piece, or the blue colored portion. And then the bony labyrinth is this outer brown colored portion of the labyrinth. Both tubes are fluid-filled. Perilymph in the bony labyrinth have a high concentration of sodium ions, while endolymph within the membranous labyrinth contains a high concentration of potassium ions. The vestibular apparatus contains two sac-like otolith organs, the utricle and the saccule, and three semicircular ducts, that's these right here, found within the semicircular canals of the inner ear. These are joined together in the same fluid environment, all of which detect acceleration. Acceleration is a change in the motion of a body. It can be a change of speed, such as linear acceleration, or a change in direction, which is called rotational acceleration. The otolithic organs are sensitive to linear acceleration, so they are sensitive to changes in velocity while traveling horizontally or vertically. And the semicircular canals, they are sensitive to angular or the rotational accelerations, which helps us maintain balance when turning the head, spinning, or tumbling. The vestibular apparatus also contains receptors for vestibular sensations. These receptors send vestibular information via the vestibulocochlear nerve to the cerebellum and to vestibular nuclei in the brainstem. The vestibular nuclei then pass the information on to various targets, ranging from the eye muscles to the cerebral cortex. Let's take a closer look at the otolithic organs. They can detect and respond to the head's position with respect to linear acceleration and the pull of gravity. There are two otolithic organs, the utricle and the saccule. The utricle is an oval tube, whereas the saccule is flattened and irregular. Otherwise, their structures are pretty similar. Each of these has a sheet of mechanoreceptor hair cells called the macula. Each macula contains thousands of hair cells that synapse with sensory endings of vestibular nerves. Each hair cell has 70 to 100 tiny cilia called stereocilia, plus one large cilium called the kinocilium. The kinocilium is always located on one side, and the stereocilia gradually become shorter. The hair cells' ciliary bundles are embedded in a gelatinous matrix that has small crystals of biogenic calcium carbonate embedded in it. These crystal particles are called otoliths or otoconia. Some people even call them ear rocks. Imagine sprinkles on top of ice cream, with the sprinkles representing the otoliths. So the hair cells in the utricle and the saccule are polarized. When the head bends backwards, forwards, or to the side, the hair cells are stimulated as the gelatinous material of the macula sag in response to gravity. This causes the hair to bend. Stimulated hair cells signal nerve fibers attached to ion channels, which open for a fraction of a millisecond, just long enough to allow potassium ions to rush through the ion channels and cause depolarization of the hair cells. That depolarization of the hair cells opens calcium ion channels at the base of the hair cell, leading to a release of neurotransmitters and resulting in impulses traveling to the central nervous system on the vestibular branch of the vestibulocochlear nerve. This informs the brain of the head's new position. The brain then responds by sending motor impulses to skeletal muscles to contract or relax in order to maintain balance. So, different hair cells are arranged in different orientations or directions so that a single sheet of hair cells can detect motion forward and back and side to side. This means that each macula can cover 2 dimensions of movement, and tilts in any direction will activate those hair cells we mentioned earlier. The utricle and the saccule lie at 90 degrees to each other. In the utricle, the macula lies in the horizontal plane of the ear, and it can determine the head's orientation in an upright position, detecting any motion in the horizontal plane, like a car moving forward or back, a left and right motion, or a combination of the two. In the saccule, the macula is oriented vertically to detect motion in the sagittal plane, for example, up and down like in an elevator. The otoliths allow you to sense movement as long as there is a change in linear motion. When you take off, land, or hit turbulence in an airplane, for example, you detect this motion because the otoliths are sensing linear acceleration and deceleration. Once you are at cruising altitude by flying, though, you do not realize that you're traveling 500 miles per hour because there's no acceleration or deceleration. A significant role of the saccule in the utricle is to keep you vertically oriented with respect to gravity. If your head and body start to tilt, the vestibular nuclei will automatically compensate with the correct postural adjustments. If you watch someone trying to stand still, you will notice constant small shifts in their posture. Unlike the otolithic organs, the semicircular ducts are not sensitive to gravity, since otoliths are not normally present in the canals. The semicircular ducts have the same basic structure as the bony semicircular canals in which they are contained. The semicircular canals are connected to the utricle at their bases. So here's those canals again, and here at the base, we're going to see those utricles. They are oriented along 3 planes of movement, which each plane at right angles to the other 2, similar to the way 3 sides of a box meet at each corner and are at right angles to one another. Pilots and astronauts have names for these 3 planes of orientation. Want to hear them? If you nodded your head up and down for yes, that is what they call pitch. If you shook your head left and right for no, they call that lateral rotational movement yaw. And if you moved your head from your left to your right shoulder and vice versa, they call that tumbling rotational movement roll. Let me give you a better example. Imagine yourself on a roller coaster ride. You start out accelerating straight ahead, just like in a car. Remember, your brain knows you are accelerating forward from rest due to the otolithic organs. Suddenly, the track dips almost straight down and you pitch forward. Then the nose of your car, and you, comes almost straight up. You have just experienced downward and upward pitch. While staying perfectly flat on the track, the roller coaster now takes a sudden left turn followed by a right turn. You have just yawed to the left and the right. Now comes the really fun part, or I used to think so when I was your age. Your roller coaster and the track do a complete 360-degree roll, first to the left and then to the right. It makes you dizzy just thinking about it, right? You have just experienced the 3 planes of angular acceleration: pitch, yaw, and roll. Your semicircular ducts enabled you to sense these rotational accelerations. As previously mentioned, the semicircular canals are connected to the utricle at their bases. At the end of each duct is an enlarged chamber called the ampulla. The ampulla contains the sensory receptors called the cristae ampullaris. The cristae detect and respond to angular acceleration and deceleration of the head. It consists of a gelatinous mass called the cupula that has mechanoreceptor hair cells embedded in it. The cupula is thicker than that of the macula from the otolithic organs, but still, these receptor cells, stereocilia, are similar to those of the macula, with the largest ones next to a cilium called a kinocilium. Okay, so when the head is at rest, the hair cells are partially depolarized and cause action potentials in the afferent neurons at a very low frequency. When the head rotates, the bony labyrinth rotates, but the endolymph within the membranous labyrinth lags because of inertia. This distorts the cupula, which leads to the movement of the hair cells in the opposite direction of rotation. Like with the macula's hair cells, the displacement of hair cells prompts stimulation of the vestibulocochlear nerve, which then transmits the information about head movement to the vestibular nuclei in the brainstem, as well as to the cerebellum. Analysis of the information allows the brain to predict the consequences of rapid body movements and signal the appropriate skeletal muscle to help you maintain balance. Each semicircle canal is responsible for detecting a particular head direction. The displacement of the fluid inside the canal informs the brain which direction the head turned. The posterior semicircular canal shown here detects when the head tilts down toward the shoulder. The anterior semicircular canal, shown here, detects when the head nods up and down in a yes motion. And finally, the lateral semicircular canal, shown here, detects when the head shakes side to side in a no motion. Each semicircular duct works in concert with a partner located on the other side of the head, which has its hair cells aligned oppositely. There are 3 such pairs. The 2 pairs of horizontal ducts and the superior duct on each side work with the opposite side's posterior duct. Head rotation deforms the cupula in opposing directions for the 2 partners. This results in opposite changes in their firing rates. When one is excited, the other is inhibited. For example, as shown here, the lateral duct's orientation makes them selectively sensitive to rotation in the horizontal plane. When the head turns to the left, the fluid in the right lateral duct moves away from the ampulla, and we get reduced excitation. And the fluid in the left one moves towards it, and we get more excitation. If the head movement is to the right, the result is just the opposite. In all functional pairs, regardless of their orientation, when a head movement raises the neural activity in one canal, its functional partner will decrease its activity. The vestibular system uses the information about movement obtained via the semicircular ducts and the otolithic organs to maintain balance, stability, and posture. One way it does this is through its involvement of reflex actions. There are 3 that we'll talk about associated with vestibular apparatus. The first one, the vestibulo-ocular reflex, often referred to as VOR, it's a reflex that coordinates eye and head movement to keep an object in focus. The VOR is one of the fastest reflexes in the human body. Head movement must be compensated almost immediately by the eyes to have a clear vision. This means when your head moves in one direction, your eyes must move in an equal and opposite direction at virtually the same speed in order to keep a target in focus. The image I have here is showing you this reflex. As the head looks to the left, the eyes move to the right. The next reflex we'll talk about is the vestibulospinal reflex, the VSR. It refers to reactions that happen below the neck. The VSR involves many complex connections that integrate input from the macula, the cristae ampullaris, the visual system, and then axial and limb muscles by the brainstem and cerebellum to maintain posture. And it stabilizes your body to maintain an upright position. So this one keeps us from falling over. And then the last reflex, this one's associated with the VSR as well. It's the vestibulo-colic reflex, the VCR reflex. In response to information from the otolithic organs and the semicircular ducts, this reflex actually activates the neck muscles that functions to stabilize the head and keeps it properly oriented in space. The exact pathways of this reflex are actually not fully understood at this time. Balance is a pretty important thing. So, disruptions of the vestibular system, whether due to some inherent pathology or to a transient state like alcohol intoxication, can involve symptoms that affect balance, like vertigo, nausea, and it can range in severity from very mild to incapacitating. Vertigo is a sensation. It is the false sensation that either the person or their world is spinning. And this is associated with vestibular malfunction. The most common cause of vertigo is called BPPV, or benign proximal positional vertigo. In most BPPV cases, the tiny crystals from the utricle have collected in the posterior semicircular canal, although it is not usually clear why this happens. When you move your head, those crystals roll around the semicircular canal, irritating the hair cells, which then transmit misleading information that doesn't match up with other sensory information, such as what the eyes are seeing. These conflicting signals lead to vertigo. Paroxysmal vertigo attacks can last for seconds up to minutes, and it could cause a person to fall because of the false sensations of movement. Remember my story at the beginning of today's lesson? This is what happened to me. Vertigo may also occur due to labyrinthitis, which is an inner ear infection or an inflammation that may have a bacterial or a viral etiology. Another dysfunction is called Meniere's disease, and this occurs as a result of an accumulation of the endolymph within the inner ear. And it can involve deafness or tinnitus because of the cochlear's involvement. Tinnitus or tinnitus is a ringing or humming sound in the ears. Vertigo is also a common symptom of Meniere's disease because of the labyrinthine involvement. One of the most common disturbances related to vestibular function is motion sickness. Motion sickness is characterized by vertigo, nausea, vomiting, and is precipitated by repeated vertical movements. Most people readily adapt to such movement, but particularly sensitive people become ill when traveling in a car, boat, or airplane. Motion sickness can also occur when there is a disagreement between the motion and orientation signals provided by the semicircular ducts, the otolithic organs, and vision. Another dysfunction called mal du débarquement or the débarquement sickness is actually a common and regular occurrence that results from vestibular disturbance. It can best be described as the continued sensation of motion, rocking, or swaying that persists after return to a stable environment following prolonged exposure to motion, as one would encounter on a cruise or a long car drive or a bus or a train ride. Most individuals who have enjoyed even a few hours on a fishing boat may experience the sensation of still being on the water after they have returned to shore. Current data suggests that the vestibular system also plays a role in consciousness, and dysfunctions of the system can cause cognitive defects related to spatial memory, learning, and navigation. There are even psychological connections as the vestibular system's pathways overlap with pathways involved with anxiety, depression, migraines, and pain. Psychological conditions, when present before a vestibular disorder, may increase vestibular symptoms. Likewise, the onset of a vestibular disorder may cause psychological symptoms initially not present, such as difficulty concentrating, difficulty paying attention, poor memory, and increased or new anxiety and depression. Vestibular dysfunction, causing dizziness and imbalance, is a common yet poorly understood feature in patients with traumatic brain injury, or TBI. Damage to the inner ear, nerve, brainstem, cerebellum, and cerebral hemispheres may affect vestibular functioning. TBI refers to any form of injury to the brain resulting from a severe blow or jolt to the head. It is most commonly caused by road traffic accidents, falls, and assaults. Symptoms of TBI include headaches, dizziness, vertigo, fatigue, irritability, and memory impairment. TBI is the commonest cause of chronic disability in young adults, and imbalance post-TBI is a key predictor of failure to return to work. TBI patients with balance problems are twice as likely to be unemployed 6 months after their injury than those without balance dysfunction. A recent clinical study conducted by Cal Zolari and Associates is the first to show vestibular agnosia in TBI patients. The study aimed to link vestibular agnosia with imbalance, both behaviorally and by neuroanatomical substrate. Participants were required to undergo a multi-level assessment from reflex to perception. Patient recruitment for the study occurred between August of 2017 and January of 2020. 918 patients from St. Mary's Hospital Major Trauma Center in London, and acute TBI patients from King's College Hospital in the final 6 months were systematically screened twice weekly via consultant-led ward rounds for inclusion into the study. The main inclusion criterion was that the patient had sustained a blunt head injury requiring admission to the major trauma ward, that they were between the ages of 18 and 65, and that they had preserved peripheral vestibular function. Exclusion criteria included additional active premorbid medical, neurological, or psychiatric conditions, musculoskeletal conditions impairing balance, substance abuse history, pregnancy, and the inability to obtain consent. The 146 patients that potentially met the inclusion-exclusion criteria or were referred to the study by the therapy team were then assessed for imbalance and dizziness to audit for the presence or absence of BPPV. Patients were asked if they felt dizzy during BPPV-evoked positional nystagmus. Patients who answered no were classified as having a clinically apparent vestibular agnosia. We will revisit this later. 37 acute TBI patients in total, for whom all behavioral and MRI data were acquired in the acute phase, were recruited for the study, along with 37 healthy and age-matched volunteers to act as the control for result comparison. Before testing, and typically while patients were on the ward, any BPPV was treated by repositioning maneuvers, and migraines were also treated so that patients were free of active vestibular problems on the day of laboratory testing. The table shows patients' demographics and clinical measures, including the Mayo TBI Severity Classification. This GCS here stands for Glasgow Coma Scale, used in accidents and emergencies. The smaller the number, the more severe. Except for patient 33, over here, whose actual score was unattainable because they were intubated at the scene. Most patients' GCS scores fell in the mild range of 13 to 15. The MOI, or mechanism of injury, is consistent with TBI's major causes mentioned earlier. Road traffic accidents listed as RTA in the table, and then falls and assaults. Over to the right, we see this DAI, which stands for diffuse axonal injury. It's a form of TBI that occurs when the brain rapidly shifts inside the skull during injury. 18 out of the 37 patients were identified as having BPPV. And then in the last column, on the right, it shows the patient's ACER scores. ACER is a cognitive battery test useful in the detection of cognitive impairment. It comprises tests of attention, orientation, memory, language, visual perception, and visuospatial skills. The test is out of 100, with a score of 88 and above considered normal. In addition to the information provided here, acute TBI patients completed 2 questionnaires. The Dizziness Handicap Inventory, or the DHI, provides an estimate of the perceived disability caused by vertigo sensations. And the Activity-Specific Balance Confidence Scale, the ABC scale, provides information about patients' confidence in their balance. This table shows assessments of peripheral and reflex vestibular functions. To exclude end organ dysfunction as a cause for impaired vestibular perception, all patients had VOR assessment. Testing included video head impulses testing with eye movements assessment of VOR gain. Patients were also assessed for signs of peripheral vestibular loss using the doll's eyes and the head impulse maneuvers. and assessing for nystagmus in the primary position using fundoscopy with and without visual fixation. The laboratory measures were within normal limits for all participants in the study. Vestibular perceptual testing was also conducted. To assess the patient's ability to perceive vertigo, patients sat on a computer-controlled rotating chair in total darkness and were instructed to press a button, a right or a left button, as soon as they perceived the motion and its direction. White noise was delivered through earphones to mask auditory clues. Horizontal eye movements were recorded with electronystagmography, a diagnostic test to check that the inner ear function was intact, indicating that any inability to detect self-motion in the dark was related to dysfunction of the brain and not of the inner ear. Here is a diagram of the experimental setup for this test. Raw traces for 2 subsequent rotations for patient number 8 are shown here. The top traces the electronystagmography signal. The middle and bottom right here traces the patient's button press and indicates perceived motion direction. In this example, the chair randomly rotated from rest to the left at a constant acceleration. The chair continued to accelerate until a correct button response is made, or if 5 seconds had elapsed without a correct button press or no button press, as shown here. So here is the first turn. And if you look here, there's no button press, either left or right. The second rotation, which is here, so this shows the chair velocity profile, okay? So the second rotation was also to the left, and as seen by this profile, it was slightly at an increased angular acceleration from the first, and we can also see that the patient detected the motion. Vestibular ocular threshold data is shown on the left here, and vestibular perceptual threshold is shown right here on the right. The darker red represents the healthy controls, while the pink represents acute TBI patients. The acceleration thresholds are displayed in terms of the equivalent instantaneous angular velocity at the time of threshold detection. Vestibular perceptual and vestibular ocular threshold data was analyzed using the repeated measures ANOVA test. Patients were classified as having vestibular agnosia if their vestibular perceptual thresholds were 3 standard deviations above the control's average. Patients' vestibular perceptual thresholds were higher than the vestibular ocular thresholds. Control's perceptual and vestibular ocular thresholds were not that different. Although vestibular ocular thresholds were marginally elevated in the acute TBI group, acute TBI patients' vestibular perceptual thresholds were dramatically elevated compared to controls. A perceptual threshold above 10.26 degrees per second indicated the patient was classified as having a vestibular agnosia. 15 of the 37 patients with acute TBI had a vestibular agnosia for this test. Slowed reaction times and impaired vigilance, common after TBI, could result in an elevated vestibular perceptual threshold. So all participants performed a visual reaction time task to control for this. Participants were required to press a right or left button as quickly as possible in response to a left or right pointing arrow that appeared on a screen. Mean reaction times were measured from stimulus onset to the time of a correct button push. Reaction times of patients with and without vestibular agnosia were tested using an independent sample t-test. Patients were significantly slower than healthy controls by 1/100th of a second. This was consistent with previous findings in TBI patients. Notably, reaction times were not different between TBI patients with and without vestibular agnosia. Overall, these findings were insufficient to explain elevated vestibular perceptual thresholds in TBI patients with vestibular agnosia. Postural sway using a force platform was measured under 4 conditions. Each had a duration of 60 seconds. Hard surface with eyes open, hard surface with eyes closed, eyes open, eyes closed, a soft surface with eyes closed, and a soft surface with eyes open. Those were the 4 conditions. This test required patients to stand with their arms hanging loosely by their sides, heels 8 centimeters apart, while being told to maintain their balance as best they could. The 4 conditions varied in sensory feedback. In the table here, controlled results are shown in the light blues. Acute TBI patients without vestibular agnosia are gray, and acute TBI patients with vestibular agnosia are the darker blues. Differences in sway area were tested with a repeated measures ANOVA test. Patients were classified as balance impaired if their average sway in the vestibular-mediated condition, which was the soft surface with eyes closed condition, this one here, soft surface with eyes closed, if it was 3 standard deviations above the control's average. TBI patients with vestibular agnosia were more unstable than controls in all conditions, while TBI patients without vestibular agnosia were more unstable than controls only in the vestibular-mediated condition. Remember, that was the soft surface with eyes closed condition. Moreover, TBI patients with vestibular agnosia were more unstable than those without vestibular agnosia on both soft surface conditions. Recall that acute TBI patients had initially completed 2 questionnaires, the Dizziness Handicap Inventory, or the DHI, that provided an estimate of their perceived disability caused by vertigo sensations, and the Activity-Specific Balance Confidence Scale, or that ABC scale, that provided information about patient confidence in their balance. So here we're going to use that information. Differences in dizziness symptoms between TBI patients with and without vestibular agnosia were tested via independent sample t-tests. Linear correlations assess whether dizziness symptoms scores from the DHI predicted vestibular perceptual thresholds, and whether balance confidence from the ABC score predicted objective balance via the posturography that we did. That's the different standing on the different surfaces. Differences in balance confidence between groups were tested via independent sample t-tests. Importantly, the DHI did not differ between TBI patients with and without vestibular agnosia. Similarly, the ABC scale did not discriminate between patients with objectively impaired balance via the posturography versus those with preserved balance. Thus, acute TBI patients with signs of an active peripheral vestibular condition, such as BPPV, may have no vertigo, and conversely, those with overt imbalance on examination may not complain of imbalance. During the recruitment period, potential subjects were assessed for imbalance and dizziness to audit for the presence or absence of that BPPV. Patients were asked if they felt dizzy during BPPV-evoked positional nystagmus. Patients who answered no were classified as having a clinically apparent vestibular agnosia. Of the 30 patients with BPPV, 16 were diagnosed by the screening process, and 14 were referred for dizziness or imbalance by the therapy team. Referring to the diagram, the left here shows patients with BPPV that were diagnosed after being referred by the ward clinical staff, while the right shows patients with BPPV who were not referred but diagnosed by systematic screening on the trauma ward. The dark red sectors represents the proportion of patients who reported dizziness during different maneuvers. These are the patients without vestibular agnosia. The light pink sectors report or represent patients with vestibular agnosia. They had denied dizziness on direct questioning during the maneuvers that triggered vestibular nystagmus, indicative of the BPPV. Okay, so only 7% of the referred BPPV cases had clinically apparent vestibular agnosia, whereas of the BPPV cases diagnosed by screening, 50% had a clinically apparent vestibular agnosia. What this means is that vestibular agnosia reduces the probability of BPPV being identified by clinical staff. The team also carried out MRI brain scans to investigate differences in the brain's white matter connections in brain-injured patients compared to healthy volunteers. We discussed white matter a few weeks ago when we were learning about the central nervous system. Recall that white matter is equivalent to the brain's electrical wiring, and damage to the white matter affects brain function by reducing the transmission of electrical communication between different brain regions. The whole brain white matter microstructure was assessed with diffusion tensor imaging, which is DTI, via fractional anisotropy, which is FA, and mean diffusivity, MD. The results of FA track-based spatial statistics contrasts are in blue, so we see the blues here. Okay, and then the yellow represents the MD, track-based spatial statistics. These images were then correlated with vestibular-mediated posturography. That was where they were standing on different surfaces with their eyes open or closed. Vestibular perceptual thresholds. We get this information from the computer-controlled chair that moved right or left, and the patients had to identify the motion. And then the vestibular ocular reflex thresholds with FA and MD values. So in this diagram, this figure here, Figure A represents axial slices of whole brain comparisons. It shows significantly lower FA in acute TBA patients compared to controls in widespread bilateral networks. Remember, the FA is in blue. Looking at Figure B here, it shows that acute TBI patients with impaired balance displayed significantly lower FA and significantly higher MD compared to acute TBI patients with preserved vestibular-mediated balance. C here shows that vestibular-mediated balance performances, so now we're talking about the soft surface eyes closed condition, was negatively correlated with FA values across all participants, acute TBA and controlled together, in a widespread bilateral white matter network. Similar findings were found for increased MD. Acute TBI patients showed significant correlations between DTI and vestibular-mediated sway performance in numerous predominantly right hemisphere white matter tracts, whereas the control group alone showed no DTI balance performance correlations for either MD or FA. Here in Figure 4, it shows an orthogonal view of the areas of the inferior longitudinal facialis where patients with impaired balance showed significant positive correlations between MD and vestibular perceptual thresholds. The higher the MD value, the more severe the vestibular agnosia. These findings suggest that damage in the right posterior thalamic radiation, the right sagittal stratum, and the right external capsule are implicated in imbalance in vestibular agnosia patients. Figure E again shows an orthogonal view of the right wider The right white matter areas where patients with impaired balance show significant negative correlations between the vestibular ocular reflex thresholds and MD. MD's in yellow. And then between vestibular ocular thresholds and FA, which is in blue. So we're seeing the blue and the yellow together. The study provides evidence that, in general, after TBI, FA decreases and MD increases relative to control values. No significant correlations with vestibular parameters, perception, or reflex were found in the left inferior longitudinal fasciculus, confirming the right lateralized vestibular cortical representation. In acute TBI patients, vestibular-mediated postural instability, most prominent when standing in the dark and on an uneven or soft surface, is mediated by damage to brain areas that are also involved in mediating the vestibular perception of self-motion. The main findings of the study were that balance impairment in acute TBI is primarily of a vestibular-dependent pattern, and the degree of imbalance correlates with widespread bilateral and predominantly frontal white matter parameters on DTI. In patients with impaired balance, DTI metrics of white matter in the right inferior longitudinal fasciculus correlated with the degree of vestibular agnosia. Out of the 37 patients with acute traumatic brain injury, 15 were diagnosed with a newly characterized neurological diagnosis called vestibular agnosia. This condition causes loss of vertigo perception and imbalance. They also found that vestibular agnosia patients were more unstable and had diffuse white matter damage in the brain than healthy volunteers. The study also showed that treatable inner ear conditions were 7 times more likely to be missed by doctors in the affected patient group because patients had little or no vertigo perception. Are there any questions?